Hey everyone, and welcome to this explainer. If you've been exploring alternative health forums lately, or maybe diving deep into off-label treatments, you've probably seen some, well, incredibly wild claims about a compound called DMSO and its effects on vision. So today, I want you to step right into my office, grab a seat. We're going to put on our medical consultant hats and objectively review a really comprehensive 2026 One Day MD article that details the off-label use of DMSO for eye conditions. We're going to look at the data exactly as a clinician would when advising a patient. All right, let's get started. So here's the million-dollar question we need to address right out of the gate. Is DMSO a miracle cure or an experimental risk? Look, it is completely understandable why patients turn to the internet when dealing with chronic pain or failing eyesight, right? When conventional options run dry, desperation sets in, and literally anything that promises relief sounds like a miracle. If you read the community reports, DMSO sounds like the magic answer to everything from dry eyes to macular degeneration. But over in the clinical world, it represents a totally unquantified experimental risk. Our goal today is to strip away all that internet hype. We're going to look purely at the medical evidence to find out exactly where the hard science stops and where the speculation begins. To do that, we have to draw a hard line in the sand right now. DMSO is FDA approved for exactly one medical use, an intravesical treatment for interstitial cystitis. In plain English, that's an approved treatment that goes directly into the bladder. Putting it in your eye, that is a purely experimental, off-label application. There are absolutely no FDA approvals for using DMSO in ophthalmic therapy. None. I really want you to keep that medical reality firmly in mind as we evaluate the rest of this data together. Okay, here's our roadmap for today's consultation. We'll hit the DMSO eye paradox first, then look at how it works biologically. Next, we'll weigh the strong evidence for inflammation against the much weaker evidence for things like cataracts. After that, we'll cover the non-negotiable safety rules, and finally deliver a clinical verdict on protocols. All right, Section 1, the DMSO eye paradox, 4,700 patient accounts versus regulatory reality. You know, DMSO has this fascinating, almost dramatic history. It was researched heavily back in the 1960s, but U.S. trials were abruptly shut down due to regulatory restrictions following an unrelated death and a high-dose animal study. Yet, it never really disappeared. It just kind of went underground. It persisted in veterinary medicine and integrative health circles. Believe it or not, our source article references a modern compilation of over 4,700 reader-submitted accounts claiming incredible eye benefits. That is a massive amount of anecdotal data for an unapproved therapy. There's an undeniable irony here. People are voluntarily putting a powerful industrial-strength solvent into the delicate tissues of their eyes based purely on internet consensus. Moving right along to Section 2, mechanisms, or how it works, the biological plausibility. Before we judge those 4,700 claims, we really have to look under the biological hood. As a consultant, my first question is, how could one highly polar molecule theoretically impact so many completely different, complex eye diseases? What's the engine driving this trend? The answer is that it's like a molecular Swiss Army knife. It's not just a single target drug. Let's walk through these. First, corneal concentration. DMSO naturally concentrates up to 4 times higher in the cornea than in other tissues, literally drawing out excess fluid like a sponge. That explains why it theoretically helps with corneal edema. Next is VEGF inhibition. It targets abnormal vessel growth, which is actually very similar to how those super expensive anti-VEGF injections work for macular degeneration. Then protein stabilization. The working theory is that DMSO could help dissolve the misfolded proteins that clump up to cause cataracts and floaters. Finally, acetylcholinesterase inhibition. This basically stimulates your parasympathetic tone to naturally increase tear secretion for dry eyes. So biologically speaking, there is actually a very clear mechanistic rationale for why people are trying this out. Section 3, strong evidence regarding inflammation and the retina in veterinary trials in animal models. So, where is the actual measurable proof to back up that cool biology? I always have to remind my patients, in the medical hierarchy of evidence, a carefully controlled animal study ranks significantly higher than human internet anecdotes. This is the strongest scientific evidence we actually possess on the subject right now. Just look at this number. 95.4%. In veterinary gold standard trials, researchers study dogs suffering from chronic superficial keratitis, which is a really severe inflammatory eye disease. When DMSO was combined with steroids, it caused a massive 95.4% repigmentation of the nictitating membrane. It drastically outperforms steroids alone. Why? Because DMSO acts as this incredible carrier, pulling the drug right into the tissue while adding its own distinct anti-inflammatory punch. And then there's this critical data point from a rigorous 2025 rat study on diabetic retinopathy.
This research showed that a 50% DMSO injection actually preserved retinal function. It actively reduced inflammation and significantly increased electroretinography B wave amplitude, which is a fancy way of saying it helps preserve the electrical signaling of the eye itself. The big takeaway here is that when it comes to inflammation, vascular issues, and retinal preservation, the animal data isn't just a whisper, it's a remarkably loud, consistent signal.
Section 4. Weak evidence. Cataracts, focus, anecdotes, hype, and speculation. Because, folks, that animal data is exactly where the hard science stops and the speculation takes over. Let's talk about cataracts and focus disorders. This is where the community reports are the absolute loudest, but the objective science is just crickets. I really want to hammer this point home with a direct quote from our source material. No controlled human trials confirm cataract reversal or floater elimination via DMSO. As your consultant today, this is where I have to offer a firm reality check. The internet is completely flooded with these miracle stories of floaters magically dissolving in days or dense cataracts clearing up without surgery. I totally get the intense desire for non-invasive cures, I really do, but we have to maintain objective medical boundaries here. There is literally zero controlled human clinical data proving this works. Let's just contrast these two ends of the evidence spectrum for a second. On one side, you have strong evidence, peer-reviewed veterinarian randomized controlled trials for inflammation showing highly measurable clinical endpoints. Rock solid. On the other, weak evidence, completely uncontrolled, self-reported human anecdotes for cataracts and floaters, almost always lacking formal medical diagnostics. Actually, scratch that. They're mostly just guesswork. Why does this contrast matter? Because placing bets with your precious eyesight on unproven theories is incredibly dangerous. While DMSO's protein-stabilizing action provides a neat theory for cataracts, it completely lacks the clinical confirmation required to actually recommend it.
Section 5. Safety, toxicity, and risks. The non-negotiables in ocular therapy. This brings us to the absolute most critical part of our consultation. If a patient sits across the desk from me wanting to try an experimental therapy, the very first rule of medicine always applies. First, do no harm. So what are the actual risks associated with putting DMSO in your eye?
Well, before we even talk about physical toxicity, we need to address the very real danger of false hope. 1, 2, 3. That is the exact number of patients in the only modern placebo-controlled human trial on DMSO for the eye. It was conducted way back in 1983 for a condition called retinitis pigmentosa. The result? Zero. Absolutely zero significant benefit. It is a highly sobering data point that sits in direct, uncomfortable tension with today's glowing internet anecdotes. Now, what about actual physical harm? Historically, you might have heard claims that DMSO actually causes cataracts. Where did that even come from? Well, it came from this documented fact. Repeated intraocular injections of high-concentration DMSO directly into the ocular tissue caused cataracts in rabbit studies after 6 to 8 weeks. However, the medical nuance here is absolutely vital. Topical drops dilute rapidly as they pass through the eye and appear safe in human studies. The danger documented in the literature is tied directly to high-concentration repeated injections, not standard drops. Still, because DMSO is such an incredibly powerful solvent and carrier molecule, there are absolute safety constraints if someone chooses to use it. These aren't just gentle suggestions, folks. These are non-negotiable rules. First, never, ever wear contact lenses with DMSO drops. It can literally dissolve or trap the lens material right against your eye. You must wait at least 2 hours after using any other eye medications because DMSO will pull them deeper into your eye in completely unpredictable ways. Use only 99.9% pharmaceutical-grade DMSO, and it must be stored in glass. It can actively leach toxic chemicals out of plastics. And finally, if you've had cataract surgery and have intraocular lenses, or IOLs, exercise extreme caution. The chemical interaction between high-concentration DMSO and those synthetic lens plastics is still not fully understood. All right, Section 6, Protocols and Final Verdicts, empowering your next steps. So, with all of this evidence laid out on the consulting table, how do we proceed? What protocols are people actually using out there in the real world? Now, I am reporting these community protocols to you purely for informational context. I am not prescribing them. For dry eye and surface issues, users report starting very low, at 3 to 10% in sterile saline, used once or twice daily. For severe inflammatory issues, the concentration jumps to 30 to 50%, but this is strictly done under medical supervision. And for peripheral eyelid issues like styes, 25 to 70% is applied topically to the skin of the eyelid with a swab, never dropped directly into the eye itself. The universal golden rule among these communities is that you must start at the absolute lowest concentration and only ever proceed under professional guidance. And that brings us to my bottom line advice as your medical consultant today. Step 1, get a formal, objective diagnosis from a licensed ophthalmologist. You simply cannot treat what you haven't properly diagnosed. Step 2, if conventional treatments have entirely failed you, discuss a carefully monitored trial of this off-label therapy with your healthcare provider. And step 3, the most important of all, never, ever replace urgent, sight-threatening care like treatments for a retinal detachment or acute glaucoma with unproven self-experimentation. Just don't do it. I'll leave you with this final provocative thought to chew on. Based on the stark difference between the rigorous animal data for inflammation and the purely anecdotal, unproven claims for things like cataracts, you really have to ask yourself, are the experimental risks of DMSO truly worth the anecdotal rewards for your specific condition? Only you, in careful consultation with a trusted eye care professional, can answer that question for your own health journey. Thanks so much for stepping into the office for this explainer. Stay curious and stay safe.